Hi, my name is Angela Siriopoulos. My student ID is 101-466-011, and I'll be answering the critical thinking question at the end. May I come in?
Yeah.
I'm going to sanitize my hands and put on my gloves. Hi, my name is Angela. I'm going to be your post-op RPN helping you today. Miss Y, can I verify your ID band with your name and date of birth?
Yeah.
Okay, Miss Y, and your date of birth is correct to what you said. Okay, so I noticed in your chart you're having some diffuse abdominal pain. I'm going to be doing a focus assessment to see if we can identify that pain. Is this all right with you? Are you okay with this?
Yeah.
Okay, perfect. I'm going to set some things up. I'm going to raise the bed, ensure adequate lighting, and provide privacy in the room. And first, I'm going to ask you a couple of questions to make sure that the pain is related to possibly constipation and not related to your surgical incision or where you had surgery, okay? So when did your pain begin?
Yesterday.
Yesterday? And what activities caused you to have this pain?
Walking and eating.
What does this pain feel like?
It feels
that
like
cramping, that fullness.
Yeah.
And where is this pain in your abdomen?
Everywhere.
It's everywhere, all throughout your abdomen?
Mm-hmm.
So what would you rate your pain on a scale of 1 to 10?
An 8.
An 8? And does your pain come and go?
No, it's constant.
It's constant, okay. So now I'm going to be doing a set of vital signs. So I'm going to take the blood pressure, the respiratory rate, the heart rate, the SpO2, and the temperature. And I do note that there's no infection with the temperature, no signs of fever. And I know that the respiratory rate and the blood pressure are a little bit elevated, probably due to all that pain. So we're going to prepare for your focus assessment. I want you to raise both of your knees so that I'm able to put this pillow underneath for your comfortability. And now I'm going to begin with the focus assessment. I'm going to lower the side railing and I'm going to expose the abdomen. And the first thing I'm going to do is I'm going to inspect the abdomen. I'm looking for any distension, any roundness, and which I do see. I'm looking for any asymmetrical, I'm looking for scars, lesions, and most importantly, I'm looking at the surgical dressing for warmth, swelling, redness, but I do note that it is clean, dry, and intact. Okay, so, and for also, I'm looking to see the breathing, and I'm looking to see the pulsations in the abdomen, and I'm looking to see any peristalsis, bowel movement that I'm able to identify with this patient. Everything, I am noting my findings, and now I'm going to be using the diaphragm of the stethoscope to auscultate all 4 quadrants of the abdomen. And I'm going to be auscultating each quadrant for 1 minute at a time, so it's going to take me 4 minutes in total. And I am noting hypoactive bowel sounds, and I am noting that the bowel sounds are sounding sluggish towards the lower quadrants. So they're all hypoactive. And importantly for this post-op surgical patient, I am going to be listening to the aorta, the iliac artery, and the femoral artery to listen for breathes or turbulence. So I'm going to listen to the aorta with the diaphragm and with both the diaphragm and the bell. Okay. And I can listen up to 1 minute for each one of these things, and I'm going to listen to the iliac and the femoral arteries. And I don't hear any bruit or turbulence. Another thing I can do, I can listen for a splenic friction or liver friction. So from the liver post-op, I'm going to use the bell for both of these. And to listen to the liver, I'm going to listen underneath the rib. And for the spleen, I'm going to listen in between the 10th rib, which I don't hear any cause for concern. Now I'm going to begin my light percussion in all 4 quadrants. And I'm listening for those tympanic sensations. However, I am hearing like dull sensations throughout the entire 4 quadrants of the abdomen, a couple tympanic sensations at the upper quadrants, but mostly dull sensations of both the lower quadrants. And I'm not doing any of these percussions at the surgical site. I'm not interfering with the surgical site. Also, I'm going to be checking, because this is a post-op patient, for ascites. So I'm going to be checking both the sides of this patient, and if I do note a dull sensation on either side, that means fluid is accumulating there. So I'll turn the patient to their side, and I'll do another percussion at the side that is elevated. And if it is tympanic, that means that the fluid has drain to the other side. So that is a positive for ascites. So I would be checking that with this patient. That's it for percussion. I can also percuss the location if the patient's able to, if they're able to tolerate, of the liver, to get the liver size to check if it's 5 to 7 centimeters. And I'll go from dull points. I'll go percuss upwards from the umbilicus to assess where that dull point is to identify the liver. And I'll also assess for splenic enlargement at the 10th rib. And I'll go in between there to assess that, and I'll have the patient take a deep breath, so I'm able to assess the enlargement. So that's percussion. So now I'm going to begin only a light palpation. I'm not going to do a deep palpation because I don't want to interfere with the healing process with the tissue, and I don't want to cause further pain. And I'm only going to do what the patient can tolerate. So I'm going to do a light palpation throughout all 4 quadrants of the patient's abdomen, and I do feel that diffuse tenderness throughout all 4 quadrants of this patient's abdomen. And that's it for my assessment. However, I do note that the patient's urinary system was functioning well, and they haven't had a bowel movement since surgery. The urinary drainage, it is like clean, it is that yellow color, and it is clear of blood clots. So they are having good urination, but however, they have not had a bowel movement and they do have pain from yesterday. I am gonna assess the patient importantly for peritoneal inflammation for that appendicitis. So I'm gonna ask the patient to flex their right leg, flex it first, and then I'm gonna ask the patient to push up against me. Good, good, and you can put your leg down. And if they have pain in their region, their iliac artery region in this area, that is an indication of that peritoneal inflammation. So some things I'm looking for post-op is I'm looking at that delayed motility. But for this patient, I am finished with my assessment. So I'm gonna thank them, I'm gonna cover them, provide privacy, lower the head of the bed, raise the side railing, and I'm gonna give them the call bell. I'm gonna doff my gloves, and I'm done with the care for this patient. So overall, I did notice that they had delayed motility with this post-op. So I'm going to be collecting my findings using the SOAP format. So the subject, they reported having no bowel movement since surgery. They reported leaving their lunch tray empty, even though they were full. They reported pain 8 out of 10. They reported pain after being with the physiotherapist. And they reported pain upon movement and upon eating. So now my objective data, I did notice facial grimacing and guarding when I was trying to do my assessment, but I didn't push further than that. Objective data, I did notice my inspection. It was rounded, distended, however the surgical site is clean, dry, intact. For my auscultation, I did listen to all 4 quadrants of the abdomen. I did notice hypoactive bowel sounds. And with the aorta and the arteries, I did not hear any bruit or turbulence. With my percussion, I did not hear as many tympanic sensations as I would like, or did not percuss for tympanic sensations. I did hear a lot of dull sensations, especially in both the lower quadrants, but I did not percuss the surgical site. And for palpation, I did palpate for diffuse tenderness throughout the entire abdomen, but I did not palpate the surgical site, and I'm not going to be doing deep palpation. So for my assessment overall, I noticed that there's delayed GI motility, there's reduced GI motility. I did also notice that with the GI tract, they have a risk for early post-operative ileus. Another thing that I noted that they're having this ongoing abdominal pain and reduced activity, and I have 2 nursing diagnoses prepared. Firstly, I have constipation related to their post-operative status and their opioid use and their decreased mobility as well, as evidenced by the abdominal distension that I noticed in the inspection, hypoactive bowel sounds that I auscultated for, and absence of recent bowel movement. My second nursing diagnosis is imbalanced nutrition, less than body requirements related to decreased appetite and abdominal discomfort as evidenced by the untouched meal tray and the reported fullness. So now my plan for this patient, I'm going to come back and I'm going to reassess. I'm going to report my findings to the doctor, and hopefully a stool softener can be prescribed or further assessment can be taken. My plan for this patient is to encourage fluids, encourage mobility, and hopefully we're going to be taking those electrolyte levels, and we're going to review if the patient needs electrolyte or potassium, and we're going to be monitoring for absent bowel sounds, nausea, vomiting, unable to pass BM or flatus. So now, for the critical thinking question at the end, what is the role of docusate sodium? So docusate sodium is a stool softener provided for patients like Mrs. Y who are struggling with constipation, so post-op constipation. And the mechanism of action for this drug, the stool softener pulls fats and water into the stool to change the surface tension to become softer so that it's able to be expelled through the bowels. But it doesn't cause contraction of like the bowel walls like a laxative or anything. It just allows the surface tension of the stool to become softer itself. And key patient teaching, so it is going to take 1 to 3 days, but do not stop taking the docusate sodium. Take it with water, make sure you're having your fiber, encourage the mobility, and report abdominal pain, vomiting, nausea, unable to have a BM, absent bowel sounds, and continue to use your opioids while you're on this medication. And that's everything.